Hester Davis Fall Risk Assessment Scale and identified areas for improvement. Falls remains one of the most common adverse events in healthcare. Falls are the second leading cause of unintentional injuries and deaths worldwide. According to the Agency for Healthcare Research and Quality, 29% of patients who fall in the hospital will fall at home. 35% of those patients will likely be readmitted for fall, and 5% of those patients will possibly die within a month. Inpatients' falls are a global problem, but also a major concern in our medical center. For that reason, I wanted to dedicate some time to go over Hester Davis assessment tool and evidence-based practice interventions to improve our patient outcomes. The objectives for this presentation are to identify the impact of falls on patients and the organization, identify potential areas of opportunity for Hester Davis interventions, define the 5 Ps of purposeful rounding, and lastly, integrate purposeful and environmental rounds in the clinical practice. In this section of our Southern California Regional Fall Prevention Policy that applies to our local medical center, I wanted to focus on the definition of anticipated physiological falls. By definition, it's when a patient has been determined to be at risk for falling and the cause of the actual fall can be logically attributed to the known and predictable risk factors such as weak or impaired gait, use of assisted device, impaired mentation, alterations in balance, strength, or mobility, anticipated drug reaction or side effects in response to treatment. This type of fall constitutes for the majority of our inpatient falls. Most risk assessment tools that exist are designed to predict this kind of fall. There are different fall assessments tools that exist today to predict anticipated falls in the acute care setting. Here at LAMC, we use the Hester Davis Scale Fall Risk Assessment. This tool was developed to predict anticipated falls in the adult population with known fall risk factors. The Hester Davis Scale is an evidence-based assessment and intervention tool with the highest sensitivity compared to other fall risk tools in the market. Each category in the Hester Davis Fall Risk Assessment tool comprises of known predicting factors that often contribute to inpatient falls. These known predicting factors include any recent fall history of falls, which exponentially increases the likelihood of falling again. For mobility, if your patient reports any dizziness with ambulation, it's best to offer a bedpan, urinal, or commode, depending on the patient's clinical assessment and severity of symptoms. If your patient requires one-person assist or uses assisted device to support their ambulation, try anticipating your patient needs by proactive restroom breaks. It's best to use these proactive breaks after breakfast, lunch, and dinner. Current research has linked proactive restroom breaks with fewer call light disruptions. Medication assessments include cardiac medications that affect the preload, afterload, and heart rate. Diuretics will often cause urgency in your patients, thus increases the chance of them getting up without calling. Please remember to use a bed alarm for these patients. Other medication classes that Other medication classes include medications that affect the central nervous system and chemo medications. Please keep in mind that polypharmacy is another risk factor that is associated with 67% of falls. By definition, polypharmacy is more than 5 medications. Totality needs. Again, consider proactive breaks for those who need physical assistance. Volume or electrolyte imbalances. Think about your hemodialysis patients. Communication or sensory assessment. Please be sure that your patient education is provided in the patient's primary language for non-English speaking patients. Behavior assessment. If you identify that your patient is impulsive or unable to follow commands, assure that you are always using the bed alarm or chair alarm. It's also recommended to keep the patient door open. The more risk factors you identify in your patient assessment for fall shall require you to have more nursing interventions in place to reflect and support your assessment. We'll go over some examples in later slides. Before I go over Hester Davis fall interventions, I wanted to share some areas of opportunity in the Hester Davis assessment. For medication assessments, please be sure to select all that apply. This includes PRN medication, one-time dose, and all medications that are ordered within the 24 hours time frame. For electrolyte assessment, account for all electrolytes that are outside of normal range until lab results have confirmed that the values have returned to normal limits. For IV fluids and tube feeds, please remember that intermittent feeds and fluid infusions should also be included as part of your assessment. For communication and sensory assessment, oftentimes nurses forget to include reading glasses. You may have to prompt this question if you're not aware. For neuropathy, keep in mind our diabetic population. 50% of our diabetic population have diabetic neuropathy, so this should also be included in your assessment. As part of neuropathy, keep in mind anesthetic nerve blocks and sensory loss or pain secondary to spinal cord also is included as part of your assessment. For behavior, take note any history or active depression or anxiety. Excessive fear of falling is frequently associated with depression, which increases the risk for falls. Both depression and fear of falling Both depression and fear of falling are associated with impairment of gait and balance. Hester Davis is a reliable and validated tool for the acute care setting. Correctly identifying patients at risk for fall is the first step in any fall prevention program. Without accurate risk prediction, implementation of fall prevention interventions is subjective at best. Having the ability to predict and prevent falls is fundamental in your clinical practice. Your fall interventions should include universal fall precautions, plus interventions that are specific to your risk assessment. Your interventions will vary from patient to patient depending on the level of risk and individualized assessment. All patients, regardless of level of risk, low, medium, or high, will require a fall ID ban. I cannot stress enough the importance of sharing your fall risk assessment findings with your patient and what interventions you have put in place to help keep them safe. In the next few slides, I'm going to share some opportunities for correct Hester-Davis charting. I have three examples of actual RN Hester-Davis assessments and intervention charting to review for your learning. The most common theme I'm finding in nursing staff are not individualizing Hester-Davis interventions by overcharting. This is a screenshot of real staff documentation. Based on this assessment, I know the patient has a low fall risk due to the total score of 10. The main area of concern for fall risk is volume and electrolyte imbalance. Areas of concern will be shown in red and will have a red exclamation point. The Hester-Davis interventions for this assessment should include the following components. Assessment-specific interventions where the patient scored high. For this patient, it is volume and electrolyte-specific interventions. Universal precautions. And low fall risk-specific interventions. The documentation in the purple section is incorrect. Based on this nurse's fall risk assessment, I know that the patient is considered a moderate fall risk due to the score of 12. The main area of concern for this patient is mobility, toileting needs, which is highlighted in red. The Hester-Davis interventions for this assessment should include the following components. Assessment-specific interventions where the patient scored high, universal precautions, and moderate fall risk interventions. The documentation in purple demonstrates that this documentation is incorrect. For this example, I know the patient is considered high risk due to the total score of 18. The main area of concern for this patient is mobility, mental status, toileting needs, volume electrolyte status, and communication, which are all highlighted in red. The Hester Davis interventions for this assessment should include the following components that where the patient scored high: universal precautions and high-risk interventions. The area where it's highlighted in purple shows that's incorrect in documentation. In the next slide of the presentation, I'm going to focus on purposeful hourly rounding and environmental checks, as it is part of our Southern California Regional Fall Prevention Policy that applies to our local med center. Purposeful rounding has been proven to increase quality of care and patient satisfaction. Purposeful rounding gives staff the opportunity to proactively address the most common patient needs, which include pain, position, potty, possessions, and plan of care. The success of purposeful rounding is highly dependent on the nursing staff prompting questions related to the 5 Ps. Prompting includes, how's your pain? How are you comfortable? It has been 2 hours since you last changed positions. Do you need assistance to the restroom? I have time. Do you have all your belongings within reach? What is important for you to do today? Do you have any questions about your plan of care? Before leaving the room, it is best practice to communicate when you will return. You can say, is there anything else I can do for you? I have time. And document the completed round. Ideally, purposeful rounding shall be done every hour from the hours of 6 a.m. to 10 p.m. and every 2 hours from 10 p.m. to 6 a.m. Purposeful rounds is a shared responsibility among staff on the unit, including ADAs, NAs, relief RNs, and primary RNs. Environmental hazards are any objects or physical circumstances in the environment that increases a person's risk for falling. Environmental checks have been proven to reduce the risk of falls and falls with injury by identifying and eliminating the environmental hazard. The acronym Be Safe is an easy way to remember all elements of the environmental safety check. Be Safe includes beds that should be locked and in a low position, alarms on, front side rails up. E for equipment. Assure that your patient has a clear path to the bathroom and assisted devices near reach. And please remember that cords should be off the floor at all times. S for signage, such as fall signs and care boards should be updated to remind patients and staff of potential fall risk. A for anticipate needs. This includes good lighting, call light within reach, proactive restroom breaks, and pain management. Floors should always be dry and free from clutter. E for education, the patient and family at least once a shift. In the next few slides, I'm going to point out some common environmental hazards that were captured during rounds. Please take some time to identify the environmental hazards recognized in this picture. As previously mentioned, the patient needs a clear pathway to the restroom. Opportunities and interventions to improve the safety of this environment include assuring a clear path to the bathroom by removing equipment and straightening cords off the floor. Please take some time to identify the environmental hazards recognized in this picture. Opportunities and interventions to improve the safety of this environment include clean up cable cords. It is important to remove environmental hazards for patients and staff, as loose cables are a common trip hazard in both anticipated and unanticipated physiologic falls. Please take some time to identify elements of the environmental check. Opportunities and interventions for this environmental check include assuring that patient belongings are within reach, such as the urinal and pitcher, and the call light within reach. This next section of this presentation will discuss RN responsibilities related to inpatient falls. Post-fall RN's responsibilities include complete full body assessment, vital signs, identify if there is a change in mental status or in their physical assessment, notify your ADA or house supervisor, and the primary physician. In addition to your physical assessment, it's also important to complete a new Hester Davis assessment and implement the required interventions and safety equipment. Also complete a post-huddle form, and don't forget your URR. Other nursing responsibilities include documenting the fall on the shift and the type of fall that occurred. Please be sure to document whether it was an observed, assisted, or if the patient was found on the floor, if the patient reported the fall. Region has created a general post-fall note smart phrase. You all have access to this smart phrase. This is a great resource to capture the sequence of events and nursing interventions that were taken in response to the patient fall. The smart phrase is called fall note. Thank you for listening. This concludes the end of my presentation.
Stop recording.